Thanks so much for the organizers for the opportunity to tell you a little bit some things we've been trying to work on. I started my lab in January 2020, so it's definitely been an interesting time to start a lab. And so thanks, Dr. Judge, for the really excellent setup. We're actually going to talk a little bit about some of my findings and our work, which fits really nicely with the data that he's recently showed you in talking about tumor-mediated damage. And so I won't spend a lot of time on cancer cachexia because Andy has already done that for you. But I really want to emphasize that the key component of this weight loss in cancer patients that we're interested in is skeletal muscle wasting, or the loss of muscle mass. And we think that's because it's associated with lots of poor outcomes in cancer patients. And so we think that being able to maintain muscle mass in patients with cancer will help patients to tolerate treatment better, will allow them to have better outcomes in their activities of daily living, better function. And there's also a lot of emerging evidence to suggest that the amount of skeletal muscle mass that a cancer patient has really affects both the pharmacodynamics and pharmacokinetics of the treatments that they're being given, and their ability to respond to treatment. And so, like the Judge lab, my lab is also interested in cancer cachexia, specifically in pancreatic cancer patients. And the reason for that is twofold. One is that this is a population of cancer patients who seems to be most affected by cancer cachexia. It's estimated that perhaps 90% of pancreatic cancer patients will lose at least 5% of their body weight. But this population of patients seems to lose weight early, right? So patients who have early stage disease or potentially resectable disease are still having a lot of weight loss and a lot of muscle wasting, which is different from a lot of other cancers where weight loss seems to be associated with advanced end-stage disease. And so I really think that this is the population of patients who is most likely to benefit from understanding mechanisms of cancer cachexia and from eventual anti-cachexia therapies. So what causes cancer cachexia? So for a long time, the idea has been that an increase in circulating factors in the bloodstream coming from tumors, and generally classical cytokines, is what leads to muscle wasting in cancer patients. And we know this because of a lot of animal models have shown us that increasing circulating levels of things like IL-6 or tumor necrosis factor, sometimes GDF15, myostatin, or activin, can actually lead to muscle wasting. However, what we're really starting to appreciate is that there's a lot of heterogeneity in the circulating levels of these traditional inflammatory cytokines in cancer patients. And so while one patient may have very high circulating levels of IL-6, another patient may have very normal low levels of IL-6. And I think that that explains why some perhaps basket clinical trials targeting each of these clinical pathways, some completed, some still in progress, have not really shown a lot of effectiveness of anti-cachexia treatments, perhaps because individual patients need individual cytokines targeted. And I think this fits with a lot of data that's recently emerged from several labs, suggesting that these high levels of cytokines in many tumor models that can drive atrophy, perhaps are driving atrophy through proteolysis. And so you can see here in some mouse models of cancer cachexia, large increases in the expression of what we think of as classical atrophy genes, increases in atrogen and MRF1, or increases in genes associated with the autophagy system. But several labs now have failed to show substantial increases in many of these genes in cancer patients. And particularly, you can see here in each of these four graphs, comparing the level of expression of these classical atrophy genes from control patients and cachectic pancreatic cancer patients. And so, well, we can't rule out that there's not a lot of proteolysis. We've really been interested in looking at other mechanisms through which cancer cachexia might occur, and the muscle wasting in particular. And what seems to have been a consistent mechanism is that there is dysfunctional muscle regeneration in patients and animals with cancer. And so it appears that cancer and tumors specifically damage muscle in some way and create a muscle injury. And Dr. Judge alluded to that when he was talking about increases in IgG staining and membrane fragility. And I've been really interested in what's actually causing those types of muscle injury. And so just like in many other types of muscle injury, a muscle becomes injured, we have activation of muscle progenitor cells. But in cancer patients and mice with cancer, this activation of muscle progenitor cells seems to be dysfunctional. These progenitor cells are activated, but they're unable to differentiate. So they seem to be trapped in this proliferative phase, unable to differentiate, and that leads to muscle atrophy. And so we know that this is true in cachectic PDAC patients. This is data here from mononuclear cell preps, so just digesting away all of the muscle fibers and looking at the mononuclear cells in muscle from cachectic cancer patients. And you can see as we have an increase in the amount of weight loss from an individual cachectic pancreatic cancer patient, we have an increase in the number of CD56 positive or NCAM positive cells. These are also lineage negative cells, meaning they're CD31 negative, CD45 negative, meaning that these are most likely muscle progenitor cells. And so we can see a really nice association with increasing weight loss and increasing presence of these cells, suggesting that we do indeed have that muscle block in differentiation and accumulation of these muscle progenitor cells. And so I've become really interested, as I've said, in what's causing this muscle injury. And so we know that this is an environment problem. If we take these muscle progenitor cells out, do those mononuclear cell preps, just like I showed you earlier, and we allow these muscle progenitor cells to differentiate on a dish, they differentiate great. This is the same C26 mouse model of cancer cachexia that you've already seen this morning. And you can see we get really nice big muscle fibers. And if we actually quantify the fusion index, it's actually much better in these muscle progenitor cells that have come from tumor-bearing mice. So we don't believe that it's a cell intrinsic problem. In fact, we think it's a cell extrinsic problem. And so you can see here with IgG staining in C26 tumor-bearing mice, when we do this stain in young mice, you can see substantially more IgG staining for muscle damage or muscle stickiness in mice who are bearing tumors at about 8 weeks of age. And if we actually wait and do these experiments in tumor-bearing mice of a year of age, you can actually see that this increase in IgG staining is much worse. And this is important because cancers like pancreatic cancer most commonly occur in older individuals. So these year-old mice are a little closer to recapitulating that phenotype. And so I've become really interested in what this damage is. And so we have some evidence to suggest that it actually is a disorganization of the extracellular matrix proteins. And so this is an electron micrograph from a tumor-bearing mouse. It's actually a year-old tumor-bearing mouse. And so we have muscle fiber membrane here, muscle fiber membrane here, and here. And then you can see this intercellular space is full of these long fibrils, which we believe are disorganized collagen. And so you can see here some examples from the C26 mouse here over here and a closer projection here. Another mouse model of cancer cachexia that we commonly use, the LLC mouse. Again, you can see this hair-like projections along the muscle membranes, which we think are disorganized extracellular matrix. But what's really important, and what my lab really tries to do, is think about if the questions we're asking are translatable to patients and could eventually be part of patient therapies. And so again, you can see what appears to be this disorganized extracellular matrix in patients with cancer cachexia. So we can see these nice, smooth muscle membranes here in a control patient, patients who have lost about 10% of their body weight here. You can see wavy membranes and some disorganized collagen out here. And then you can see in a patient with substantially more weight loss, lots of these hair-like collagen projections, suggesting that this disorganization is happening and is progressive. And so we really believe that it's disorganization of the matrix because one of the things we know well and has been shown by several labs is that the expression of the genes that make up collagen 1 is substantially decreased in almost every model of cancer cachexia we've looked at, and particularly is decreased in patients with cancer cachexia. And you can see that here. And so you've already seen this data today that the predominant genes that are differentially expressed in patients with pancreatic cancer are downregulated as shown in blue. But when we do the functional components of those genes, what we find is the majority of these genes in our hands are associated with the extracellular matrix, with collagen trimers, extracellular matrix, collagen fibrils, and fibrillar collagen trimers. And so when we do second harmonic imaging, and I'm sorry, this image didn't show up very well, but you can actually see around individual muscle fibers of control patients some intact collagen structure. However, when we do similar imaging in cachectic pancreatic cancer patients, we seem to have lost that structure. And that's better appreciated here. So this is a high resolution SIM microscopy image of muscle from a control mouse. You can see red staining here is PAX7, DAPI in blue, and then green is actually stained for collagen 1. And so you can appreciate in this individual muscle fiber membrane, you can appreciate the individual collagen fibrils. And when we do similar imaging on muscle from cachectic mouse, I hope you can appreciate that these collagen fibrils have been lost or seem to be disorganized. And so when we rotate the Z stacks of these images, you can actually really appreciate, this is the muscle fiber membrane here, and these collagen fibrils seem to be lost. And so I'll show you here and rotate again in the control mouse. Hopefully you can appreciate these long collagen fibrils, that intact collagen structure. And so we really think that one of the early events in cancer cachexia is the disorganization of this matrix, and particularly the disorganization of collagen 1. We're still working out how this disorganization occurs. We know that there's lots of immune cell infiltration that occurs in cancer cachexia, and some of that seems to be an early event. But we're not yet sure if that's causative or perhaps is simply in response to the damage. And so I think that this disorganization of the extracellular matrix is actually contributing to the activation of these muscle progenitor cells. It may actually help to keep these muscle progenitor cells in this proliferative phenotype. And so I pulled out this slide, but because we've already talked about it today, I'll add that we also seem to see a sex difference in this disorder and in the decreased expression of collagen genes in cachectic patients. Although we seem to see worse disorder and worse downregulation of collagens in male patients. And so it seems to not fit with what the Judge Lab has been seeing in their female mice. And then the last point I'll make is that we think that this may be a really early event in cancer cachexia. The Judge Lab has really nicely shown that particularly perhaps later in cancer cachexia, there really is some fibrosis and scarring in patients with cancer cachexia. And so we think that perhaps this is an early event leading to some later events where we get some fibrosis and more traditional muscle pathology, which I'm sure many of you are familiar with. So with that, I'd just like to acknowledge my postdoc mentor, Dennis Guttridge, who let me take a lot of this with him, our funding sources, and hopefully I've left a few minutes for questions.
That's perfect. Thank you, Erin. We have several minutes for questions. So I'm just going to make a quick statement that I don't think our data disagree. Erin, our more severe pathology in females is in our FOXP transgenic mice, not our tumor-bearing mice. So just, I in fact do agree with you that male mice seem to have a worse phenotype in tumor-bearing conditions. So.
Yeah.
Okay.
No, sorry. Go ahead.
Nope.
No, I was gonna say, yeah, we've really learned some lessons about having to be really careful about that, and that we are really having to make sure that we're checking equal group sizes. The incidence of cancer cachexia in pancreatic cancer patients, if you just look at weight loss, is very similar between men and women, but it doesn't seem to perhaps be the same pathology.
Agreed. Okay, Dario has a question.
Yes, thank you very much. Very nice presentation, Erin. It's really something that it's original and it's definitely, deserving more attention. First question is, are you planning to look in vitro if like, I don't know, factors from the tumor are inducing degradation of the matrix or something? And then in vivo, are you planning to look at the tendon or at the other districts and tissues, for instance, the perimysium, the epimysium, or things like that, that ultimately could actually, and this is also another question, do you think this phenomenon could contribute to the loss of force that we observe in cachexia? Maybe there are dissipations in the due to the viscoelastics properties that are changed, things like that.
Yeah, I definitely do think that there's a real possibility that this contributes to the changes in force. And hopefully we're trying to tease out ways to actually look at other tissues. And I think perhaps skin is also a good place to look because there's lots of collagen there. And if it's a circulating factor, it should also be present in affecting skin. As to your question about if we can do this in vitro, we're trying to think about some ways to do that. One of the, as you know, it's really hard to recapitulate cancer cachexia in a dish. We know that if we treat C2, C12 myoblasts with serum from cachectic patients or cachectic mice, it doesn't matter. Yes, we can recapitulate some of these changes in the extracellular matrix. And so we're trying to think about ways in which we can model that a little bit better. But yeah, it's definitely been a challenge.
And Marco.
Hi, Erin. I have a couple of questions. For instance, we do see a change in collagen gene expression in other models of muscle atrophy like denervation. And my question is, so you talk about collagen 1, but have you checked other types of collagen like a collagen 4, 6, or fibronectin lamin that are very important for the, let's say, some for the structure of the membrane, basal membrane, and others for the signaling components like collagen 6 deficiency leads to myopathy and a condition of muscle dystrophy. And my second question is, changes in collagen properties may be very often related to expression of metalloproteins that are important to remodel the extracellular matrix. So have you checked also this possibility that extracellular metalloproteins are involved?
Yeah, so we have checked collagen 3, 4, 5, and 6. At the modest resolution, we don't see much change in any of those collagens. We haven't done the super resolution microscopy for those, but they don't really seem to be necessarily very altered. You'll see they're not perfect. They're not as beautiful. You've seen lots of cachectic muscle and you know that there's lots of, the laminin is not in great shape. And so that kind of causes changes in everything. But it seems to primarily be collagen 1 that is changed. And yes, I absolutely think that it is matrix metalloproteinases that are causing this disorder. Where they are coming from has been a real challenge. And so we are going back and doing, those elegant genetic experiments to try and take out specific MMPs in different cell types to try and tease out whether it's perhaps the immune cells, as I'm sure particularly macrophages produce a lot of MMPs. And so we know that if you take out macrophages, you can see some rescue in the muscle wasting of cancer cachexia. And so we're trying to do some of those experiments, but there's also some data to suggest that perhaps it's muscle progenitor cells that are the problem. And so we're also going back and doing those experiments. And so I had really hoped in December that I'd be able to tell you about those today, but unfortunately it's been a rough pandemic and we're still working on them.
Okay, thank you.
Okay, we have about a minute left. Rick.
Yeah, quick question. I thought the ECM stuff looked great. And yesterday we had a big discussion of these paramecial cables. Do you have any evidence that the collagen is organized in cables versus fibrils and that ratio changes versus the amount of collagen changing?
Yeah, so I don't think that it's the amount of collagen changing. We've done a little bit of running it out on a gel. We're getting ready to do those hydroxyproline assays to actually tease out. We think it's all still there. We think that it's just not ordered. I don't have any evidence to suggest that it's necessarily forming cables and is beyond just a destruction of the fibrils in the order.
Yeah,
Go ahead, I'm sorry.
Oh, I was going to say, I should show you some pictures that in other fibrosis models where you can really go from fibril to cable and back. And it'd be really interesting if that's sort of how collagen is regulating stress distribution in a muscle. I've never heard of it in cachexia though.
Yeah, and we're really, the polarized light microscope was supposed to be here last week to be able to actually start to address those things. I know that's really going to answer a lot of questions for us. I'm holding the Picker Serious red stain slides. I'm so excited, but unfortunately our microscope's not here yet to do it. So we're getting close.